Okay, thank you, Prof. Arjun. Thank you, Dr. Penny, for the wonderful talk. And a very good morning to everybody who is here today, listening to the Breakfast at Health program. And as much as Malaysians love cats, and we heard how something so common, a common pet can cause health problems. So we are also one of the countries that is highly affected by the occurrence of chronic kidney disease, with alarming increasing numbers with our lifestyle and all that, and many patients require dialysis treatment to survive. So there are many complications in patients with renal failure, and one of it is renal hyperparathyroidism. Okay, so today I would like to introduce Prof. Khoon Leong, who is a senior consultant general surgeon and the head of our endocrine unit in the Department of Surgery. He's also our chief coordinator of the postgraduate surgical program. He has vast experience in surgical management of various endocrine disorders, and I welcome Prof. Khoon Leong to give his talk on surgical management of renal hyperparathyroidism. Over to you, Prof.
Okay, thank you, Prof. Shanggar, for your very kind introduction. I shall try to share my screen. And thank you also to UMHealth for allowing me the time this morning to give a short presentation. Unfortunately, it will not be as exciting as the first presentation. Okay, so my talk today is on renal hyperparathyroidism and what's the surgical management. So this is the outline of my talk this morning. So we'll go a little bit on the definition. Why do we need to treat this condition? The medical management, surgical management. What are the surgical procedures that we perform for this condition? Some of the complications of surgery and what are the outcomes? Okay, so by definition, renal hyperparathyroidism is a common complication of chronic kidney disease. And it is a very complex disorder, and it basically involves derangements in the homeostasis of calcium, phosphate, and vitamin D. So essentially, the syndrome is characterized by hypocalcemia, diminished excretion of phosphate, and the inability to activate vitamin D. And encompassing this, there's usually secondary and tertiary hyperparathyroidism. So I shall go into these two conditions. So what do you mean by secondary hyperparathyroidism? So essentially it means there's an elevation of PTH, or the parathyroid hormone, and it's usually secondary to hypocalcemia, hyperphosphatemia, and reduced calcitriol synthesis. So what happens, the first driving effect is actually hyperphosphatemia, the inability of the kidneys to excrete phosphate. So that is the sort of the initiator of all these metabolic derangements. Okay, so as a result of which, the parathyroid glands enlarge because they need to produce more PTH. So, and most of the time, the initial enlargement is due to hyperplasia. And basically, it's a compensatory mechanism in response to the hypocalcemia and hyperphosphatemia. And this condition may resolve when calcium and phosphorus homeostasis normalizes, as when the patient receives a renal transplant. Okay, so it is not irreversible. A secondary hyperparathyroidism can be reversed, and if the patient gets a renal transplant, then all these changes can reverse. So unfortunately, if the hyperphosphatemia and the hypocalcemia persists, what happens is that eventually the parathyroid glands become autonomous and they become unresponsive to calcium levels. So whether the calcium levels are high or low, the PTH keeps getting produced, and it is produced even in the presence of hypocalcemia, okay? And the majority of this is due to the persistent parathyroid hyperplasia, but in up to 30% of these cases, it can be actually due to adenomas and due to some monoclonal proliferation, the reason for which we are not sure. Okay. So what happens in calcium homeostasis? So to understand the problems in renal hyperparathyroidism, we need to understand a little bit about PTH activity. So PTH essentially stimulates osteoclast formation and bone resorption. It increases serum calcium and phosphorus levels. It activates 1,25-dihydroxy vitamin D. It increases calcium and phosphate absorption from the gut, and it increases calcium reabsorption and decrease phosphate reabsorption in the kidneys. So that's essentially the activity of the parathyroid hormone. And what happens is that when there is an overproduction of PTH, the calcium homeostasis is disrupted. Okay, and that is the cause for all the signs and symptoms of renal hyperparathyroidism. So this is a schematic showing you the pathogenesis of renal hyperparathyroidism. So you can see on the left side, the anti-proliferation factors. And so in renal failure, you get decrease in vitamin D, you get increased phosphate, you get decreased calcium. And all these drive the overproduction of PTH. And this, the decrease in vitamin D, increase in phosphate, will increase the production of fibroblast growth factor 23, which I shall talk about in a minute. Okay, and all these will cause vascular calcifications. Okay, what's the sequelae of renal hyperparathyroidism? So mainly three. Number one, it causes renal osteodystrophy, causes osteomalacia, adynamic bone disease, and osteitis fibrosa cystica. Number two, the major effect is on the cardiovascular system. So it causes cardiovascular disease, it accelerates vascular calcifications, and it affects the myocardium, the AV conduction system, and the valvular function. And the third thing is when the patient develops calciphylaxis, or the modern term is calcific uremic arteriolopathy, where it causes calcification in the arterioles of the skin and soft tissue. So eventually it causes vascular compromise and ulceration. And it is an ominous sign because patients with calciphylaxis have an 8-fold increase in mortality rates. And of course, when you get deposition of calcium in the subcutaneous tissue, you get what is called tumoral calcinosis. Yeah. Thankfully, it's not that common in patients with renal hyperparathyroidism. Yeah. But it is a known complication. So what are the signs and symptoms of renal hyperparathyroidism? So Pasika and Parsons came up with this list of symptoms in 2000. So when they were studying the prospective surgical outcomes based on symptoms, and I shall talk to you about the outcomes a little later in the talk. So basically things like pruritus, thirst, headaches, muscle weakness, bone pain, mood swings, abdominal pain, conjunctivitis, vascular calcifications, osteodystrophy, brown tumors, and fractures. Okay, so these are the signs and symptoms of renal hyperparathyroidism. As you can see, they are actually quite debilitating. Yeah. So what is once you have diagnosed secondary or tertiary hyperparathyroidism, basically you perform biochemical tests, and of course, sometimes you require imaging and all that. So once you've made the diagnosis, what is the medical, the management? The initial management is always medical, meaning you restrict dietary phosphate, you use phosphate binders like sevelamer and lanthanum. You also give vitamin D and vitamin D analogs, and you also try to use calcium mimetics. So what are calcium mimetics? So calcium mimetics are allosteric. They are actually, they cause allosteric activation of the calcium sensing receptor on the parathyroid glands. And what they do is that they actually inhibit PTH secretion. Yeah. Okay, so this is the initial medical management. So when to refer to the endocrine surgeon for renal hyperparathyroidism? Okay, when the patient has biochemically is difficult to control. That means the hypercalcemia and hyperphosphatemia is difficult to control, even when the patient is on maximal medical management. Okay, when the symptoms become debilitating and the patient becomes resistant to medical treatment. And of course, if the patient has complications like pathological fractures and accelerated vascular calcifications, of course, that's an indication to refer. And Schneider have shown in 2012 that parathyroidectomy is required in 15% of patients on HD after 10 years, and the percentage increases to 38% of all patients after 20 years of hemodialysis. So it is a very significant number. And in our local context, we are not seeing that many patients. And I feel that maybe the patients have not been diagnosed, so they haven't been referred. Okay. So, but these are the numbers from the West. Yeah. So what are the indications for surgery? Unfortunately, there is no firm guidelines on what are the indications for surgery. So they've been talking about it since 2003, and I can show you two slides, the following two slides. And the whole problem is because renal hyperparathyroidism is a very complex disease, and no two patients are actually the same. Okay, so their degree of metabolic derangements and so on and so forth cannot be standardized, so to speak. So that's the reason why the nephrologists, the endocrinologists, and the endocrine surgeons have not come to a consensus on what are the strong indications for surgery. But these are some of the indications. Okay, when the medical management of renal hyperparathyroidism is more than 6 months with hypercalcemia or hyperphosphatemia. Here, under the Kidney Diseases Outcomes Quality Initiative in 2003, they look at the figure of PTH more than 800 picograms per mil. When the patient has calciphylaxis, osteoporosis, T-score more than 2.5 below the standard deviation on the DEXA scan, when the patient has pathologic bone fractures, and the other soft signs are symptoms and signs like pruritus, bone pain, severe vascular calcifications, and myopathy. So these were the suggested guidelines in this Kidney Disease Outcome Quality Initiative in 2003. So from the East, we have Tominaga from Japan, who published the paper in 2005, and these are his modified indicators. So he takes a slightly lower level intact PTH of 500 when patient has hypercalcemia, hyperphosphatemia, and the Japanese actually go in and measure the volume of the parathyroid glands. So they say if the volume is more than 500 millimeters, that is an indication for surgery. And he also suggested a list of absolute indications like calciphylaxis, bone loss, anemia resistant to erythropoietin, and progression of ectopic calcifications, and so on. So there are some soft guidelines on when to refer, but basically in our local context, we usually depend on the nephrologist to initiate the referral. So when because they take care of all our CKD patients, and when they feel that these patients are biochemically difficult to control with maximal medical management, that is when they will refer to us. Yeah. So what are the pre-op investigations? Most of the time, we just look at biochemical investigations. Most of the time, I do baseline imaging, which is an ultrasound scan of the neck. It's not really terribly useful because it's very rare that we can actually see all 4 glands that are enlarged. Okay, so sometimes you find 1 or 2 enlarged glands and you can't see the rest, and sometimes you don't even see an enlarged gland on your ultrasound. Okay, but to me, I guess in my practice, I find it's worth doing an ultrasound as a baseline. Okay, whether should you do a SPECT, maybe whether you should do a CT, a 4D CT, okay, it's debatable. I don't find that it's useful in the initial stage because the pickup rate, I did routinely do a MEB scan a few years ago for all these patients, but I found that the pickup rate is not encouraging. Okay, so sometimes you see 1 or 2 hotspots. Very, very rare you actually find all 4 glands lighting up to indicate where the locations are. Okay, so I generally reserve the MEB and CT and KIV 4D CT if we have failed the initial exploration. Yeah. So basically, we just go with biochemical investigations, and basically I just do an ultrasound of the neck. So this is what it looks like on the ultrasound. You get a hypoechoic lesion on the ultrasound scan. There's another one that is from the Columbia Parathyroid Center. And so once we've decided, okay, we think that the patient has renal hyperparathyroidism and he's a candidate for surgery. So what are the common surgical procedures that we do? So these are the surgical procedures that surgeons will perform, either a total parathyroidectomy or a subtotal parathyroidectomy, total plus a transplant, or a total plus cryo plus transplant. Okay, so over here I only do either a TP or a TP plus ATX. Okay, I generally don't like doing subtotal parathyroidectomies because I find it's a bit finicky. You're supposed to take out 3.5 glands and leave half a gland behind. And how much you leave behind is actually not written down in stone. So it's agar-agar all the time. So if you leave too much, the patient will have persistent disease. If you take out too little, the patient will be will have hypoparathyroid anyway. So to me, I think it's not such a good surgery. So if I want to do surgery, I want a definitive outcome. So the best outcome is TP. So you take out everything, and TP with transplantation. Okay. And what I do is that we take out usually about probably 1 or 2 milligrams of the parathyroid and implant it in the brachioradialis muscle in the forearm. So I generally implant it. If I implant it in the forearm so that it's easier to get to in case the hyperpara recurs. Okay, and I always mark the site with a non-absorbable suture. Okay, so that's the thing. So we unfortunately here we don't have cryopreservation. Cryopreservation is a very neat solution where you actually just store the parathyroid tissue in liquid nitrogen, and if you need it, then you transplant it. But of course, the longer you keep the specimen, the percentage of viability decreases with time. All right. So we don't do it routinely. I think a lot of centers also don't do it routinely because not many centers in the world have facilities to cryopreserve the parathyroid, or they don't have the facilities. Yeah. Okay, so this is what it looks like. So this is a huge parathyroid gland. Sometimes they turn out to be this size. If they're this size, then it's easy. You just go in and you just take it out. Okay. Sometimes, most of the time, they are not that big. Yeah. Okay, this is another one. This is from Vanderplas. So this is when you see the parathyroid gland embedded in the thymus. So usually when we do a TP, we usually do a thymectomy as well, because sometimes you find the parathyroid gland embedded in the thymus. Okay. And this is a scar. Of course, I don't have a photo of the scar that we have. Most of the time, we try to site it in a skin crease, all right? But sometimes, as you know, those patients with CKD usually have very poor wound healing. So sometimes their scars are not as nice as this. Yeah, all right, this is the perfect situation. And of course, this is a real life photo of what we actually do. So as you can see, you know, all the 4 glands are all different sizes. So they don't become hyperplastic to the same degree. So you can imagine the one on the lower right side is very small, and sometimes it's very difficult to find. So sometimes you can find 1 or 2 big ones, and then, you know, you really try to find the last remaining 3rd and 4th gland, and sometimes it's difficult. And of course, going by the embryology, the inferior glands are more variable in location. Okay, so these are the more difficult glands. Yeah. So what are the outcomes? The outcomes, patients will get improved symptoms. They get improved, the bone pain decreases, their arthralgia, muscle weakness, and the psychological mood swings and all that decrease. Their bones shows increased bone mineral content. you get accelerated bone formation, you get reduction in fractures, and the important thing is you get reduction in incidence of major cardiovascular events. And studies have shown they have increased long-term survival. Okay, so these are the positive outcomes of the surgery. So Pasika and all that, I showed you this slide earlier. So she actually did a study, and the symptoms actually improved at day 7, at the 3rd month, and the 12th month for tertiary hyperparathyroidism in terms of improved quality of life, in terms of improvement of all these symptoms. And in fact, we have a study ongoing looking at the quality of life improvement in our parathyroid patients. So unfortunately, because of COVID, the study has been delayed. So it's probably going to finish later this year. And prelim results show that we actually show the same thing, that the patients actually show an improved quality of life. So what are the risks of surgery? Risks of surgery are listed: recurrent laryngeal nerve injury, very rarely superior laryngeal nerve, injury to surrounding structures, hematoma, SSI. Probably hematoma and SSIs are because the CKD patients have decreased immunity. Yeah, and of course, hungry bone syndrome. So the moment if you're successful and you manage to remove all the 4 parathyroid glands, suddenly the PTH that can be running at about 600-700 suddenly becomes 0.5. So as a result of which the calcium in the blood will all go back into the bones, okay? And that's the reason why the patients will get severe hypocalcemia. So the moment we know that the operation is successful, and usually when we take out the glands intra-op, we will send them for frozen section for confirmation. Then we will start the patient on intravenous calcium and oral calcium, okay, to ameliorate this hungry bone syndrome. Of course, the inability to locate all 4 parathyroid glands is a common complication. It's not that common, but it occurs. Sometimes, like I told you, we can find 2 glands, we can find 3 glands. So sometimes the 4th gland eludes us, okay? So when that happens, then we'll spend a reasonable amount of time searching for it. If after 1 or 2 hours we can't find it, then we'll close up. And then this is when we find that the MEB scan is useful, because if you have taken out, let's say 2 or 3 glands, and you're looking at the remaining gland, then the MEB scan after that will be useful to try to locate where the remainder gland is. Of course, in 13% of patients, they have supernumerary parathyroids. And of course, after autotransplantation, sometimes you can get a recurrence. That means the transplanted parathyroid gland in the forearm starts producing too much PTH. So I think I've reopened 2 patients that have to really go in and just take out that bit where we're implanted. Yeah, okay. But it's not that common. It's not that common. And that's the reason why we implant it in the brachioradialis muscle, so that we don't do any more surgery in the neck, and we just do it in the forearm, yeah, which is less risky because of the recurrent laryngeal nerve. Yeah. So what about surgery versus Renal Hyperparathyroidism? Okay, so there are so many studies, and unfortunately, it's not possible to do a really strict RCT on this, but studies have shown, many studies have shown, there is decreased risk of cardiovascular events for the surgical patients. It's more cost effective, and of course, you avoid the side effects of Synopsis. Okay, some patients do get GI symptoms like nausea and vomiting with Synopsis. And the cost itself, okay, so 1 tablet of Synopsis, my patient told me yesterday, cost $16. So probably you're looking at between 1,500 to 2,000 ringgit just for Synopsis. Okay, that's the extra expenses that the patient will have to bear if they are on Synopsis. Okay, so yeah. So what's the conclusion? So renal hyperparathyroidism is a complication of CKD. It can lead to bone, cardiovascular, and psychological disorders. It can lead to fractures, poor quality of life, and increased risk of death. Initial management is always medical. There are some guidelines for surgery, but they are not that strict. Okay, and of course, post-parathyroidectomy patients have demonstrated improved symptoms, reduced cardiovascular and overall mortality. Okay. Thank you for your kind attention. Yeah. So these are my references.
Okay. Thank you, Prof. Ng, for the very informative talk on a condition that it can be quite common, but the surgical uptake of the patients who undergo chronic dialysis is quite poor, I think, isn't it? What do you think?
I think when they are referred, actually, when they come to our clinic, most of the time patients are agreeable. Because by the time they come, they actually have quite debilitating symptoms, you know. They have quite severe bone pain, they get muscle weakness. So they're very symptomatic. And of course, when the nephrologists do refer to us, they are already, you know, they're already at stage. And then most of them will come with PTH of 600, 700. And yeah, and most of them will benefit. Yeah.
So because of the impact on the quality of life, therefore they agree to go for this surgery, isn't it?
Yeah, exactly. So I mean, don't need much persuasion in the sense, you know, and it's quite satisfying because if the surgery is successful, you can see the effect is quite immediate, quite fast actually, you know, and patients will tell you themselves that I have less pain and I feel better and so on. So it's quite a satisfying surgery to do. Yeah.
Sure. So I'll just go to the Q&A box here. There's a question from Prof. Tungkusara. Should dialysis patients all take supplements and have dietary restrictions to prevent this?
Yeah, I think Prof, the nephrologists will have already maximized all the medical treatment. Okay, which means phosphate binders, calcium, vitamin D, analogs, and so on. So most of the time when they are diagnosed to have CKD, they are already on all these. So immediately they are all started on this. And unfortunately, some patients will be good. I mean, they respond and they don't progress, but some patients don't. And so that is the thing. So like I told you before, in one of the slides, you know, about 15% of patients after 10 years of HD will eventually be referred for surgery. And the number rises to about 38% after 20 years of HD. So these are the breakthrough cases. Yeah.
Okay. So another question for Prof. Tungkusara. I think your one of your slides on complications with regards to an abbreviation SSI. So
yeah. SSI is a surgical site infection. Yeah, okay. Surgical site infection. Yeah. Sorry.
All right. Yeah. So that confirms that. And from Prof. YK Chan, can a patient with good dialysis arrangement, almost perfect dialysis arrangement, be less likely to develop hyperparathyroidism? Whether it is, I mean, sure that the patient on dialysis will end up with this, or
like the figures I mentioned, I think what our nephro people do, they are quite good. I mean, they maximize. I mean, they put patients on everything, all the medical management, phosphate binders, and all that, in the hope of preventing, you know, just this scenario. And I think the ones that get referred are the ones who somehow, you know, break through. I mean, they have breakthrough renal hyperpara, and they are difficult to control. Yeah. So I think our nephro team is doing a good job. I think they maximize medical treatment of all these patients, so to prevent all these complications from occurring. But unfortunately, because it's a very complex, involves a lot of complex calcium homeostasis. So we don't understand yet why some patients don't do well with cinacalcet and all that, you know, but some don't do well, even on maximal doses of cinacalcet. Some of them still get complications, so they get referred to us. Yeah.
Okay.
Okay.
So there's another question. Probably in the interest of time, this will be the last one.
Yeah.
These patients have multi-morbidity. How do you balance the risk-benefit with patients and your anesthetist colleagues?
So that's the reason most of our CKD patients have concurrent IHD, you know, hypertension and so on. So what we do, we optimize all these patients. And if they have a bad cardiac history, then we send them to the cardiologist for an assessment, and we will let the cardiologist prognosticate the cardiac risk. So if it is let's say moderate or high risk, then of course, obviously they are not a suitable surgical candidate. Then in that sense, there's no choice but to just keep these patients on Cinacalcet. So basically what we do, we will actually assess these patients quite carefully, that if there are any medical issues, we make sure we optimize it before we offer surgery to these patients. Yeah. And then it's perfectly right. I mean, a lot of CKDs have a lot of concurrent. The worst are all those with IHTs that are difficult to manage. Yeah.
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 So in conclusion, Prof. Ng, would you agree that the way forward, in order to cut costs and to avoid complications of the surgery, the difficulty of the surgery, is to encourage all renal dialysis patients to undergo renal transplant? Maybe.
I think the best thing is we should start an MDT with a nephro, to look at all these patients together, so then we can decide who are the surgical candidates and who benefit from early surgery and so on and so forth. Yeah. Okay. Yeah. Because unfortunately, not many of them are suitable for renal transplant, or the transplants, the kidneys are not available. I mean, the best treatment is renal transplant for CKD patients. No, without a doubt. Yeah.
Yeah, but of course, availability. Depending on availability.
Yeah. Okay. Correct. That's the thing. Yeah. Okay.
All right. Thank you very much, Prof. Ng, for your talk. I think with that, we shall close the session this morning with the usual thanking of all the speakers and panel.
Thank you very much. Bye-bye.